Good evening, Professor Aniqua and social work colleagues. I'm Karen Jurgens, and the research question that I've posed for this study is hyperbaric oxygen therapy effective for post 9/11 U.S. combat veterans with treatment-resistant PTSD when combined with traditional talk therapy? PTSD stands for post-traumatic stress disorder, and it can result from intense fear, having to kill in combat, witnessing death or serious injury, experiencing natural disasters, sexual trauma, etc. 2 to 3 million U.S. military personnel were deployed during the global war on terror to the Middle East, which ended in 2022. About 15 to 30% of those are estimated to experience PTSD, and their symptoms can range from mild to extreme and debilitating. The problem is not that treatments don't exist. The problem is that nearly half of this population is considered treatment resistant, which means they're not getting relief from any of the available treatments or therapy. Hyperbaric oxygen therapy is known as HBOT, and it's been shown to help relieve symptoms of PTSD and improve quality of life. A typical treatment plan involves lying in a transparent chamber, like you see here, that is fed with pure oxygen for 60 to 90-minute treatments, ideally twice a day for 5 days per week for about 4 weeks or a total of 40 treatments. The hypothesis that we'll test in this study is that hyperbaric oxygen therapy is an effective treatment for more than half of post 9/11 U.S. combat veterans suffering from treatment-resistant PTSD when it is combined with traditional talk therapy. We did a literature review of existing studies, and we found that HBOT has had significant improvements, specifically in the reduction of suicidal ideation. There's been less need for medications, improved brain function and PTSD symptoms, improvements in traumatic brain injury, which is TBI, improvements in neuroplasticity, mood, and dysregulation of the stress response. There were some inconsistencies noted due to the differences between people. No two are starting with the same exact level of the condition. Comorbidities, such as having traumatic brain injury along with PTSD, prior mental health issues, a troubled adolescence before joining the military, and other physical health conditions. The methodology is going to be described next. The instrument that we're going to use is the CAPS-5 assessment, which is the clinician administered PTSD scale for the DSM-5. Its validity score is 0.83 and its reliability score 0.88. It categorizes people with PTSD into 4 categories, 1 through 4. 0 would be absent of symptoms or not having PTSD. It's going to be mixed method, longitudinal, bivariate study done over 5 years using HBOT and cognitive behavior therapy, CBT, as the talk therapy. The independent variable is the HBOT treatment, coded PRTMT, and the dependent variable is the person's symptoms, which we've coded SYMPT. Ethics are going to be a consideration. The CAPS-5 interviews will be done in a private office behind closed doors for confidentiality of the patient. They will first sign an informed consent form, and we've already applied to the St. Leo University Institutional Review Board. The sample population is going to be non-probability purposive sampling of 100 veterans, 85 males and 15 females, 25 from each of the PTSD categories 1 through 4. 30% will be white, 30% Black, 30% Latin, and 10% other nationalities. Our data collection protocol will be that the CAPS 5 interviews will be done in person on paper, each one taking about 1 hour. We'll repeat this after 4 weeks of HBOT and CBT therapy, and then again 5 years later. Planning for retention will include birthday cards, holiday cards, giving a magnet with the date of the next visit, keeping in touch with the participants during phone calls, and things like that. If they move away, it can be done virtually. The data analysis will be the dependent sample t-test to evaluate scores pre and post treatment. We'll enter the data into Max QDA software. It will be coded by the severity of the symptoms, and the code names will protect the identity of the participants. We'll report the baseline findings. Then we'll repeat the same process 4 weeks later and run comparison reports to show the change. We'll determine if the hypothesis is true or not, and then we'll plan for the 5-year follow-up interview. These are the references that I've used in creating this study. Thank you for your time.